Hello everyone, and welcome to this video where I delve into the topic of headache. This is tailored specifically for the AGACNP board exams. As an aspiring AGACNP, I understand how challenging it is to prepare for the boards. That's why I've taken an innovative approach and created the study guide. I combined the key insights of valuable information from review courses that I took, and I blended their expertise with my personal study methods. My goal here is to share this knowledge with you, making your study process more efficient and effective. So whether you're revising your exam or looking for a deeper understanding of headaches in clinical practice, this video is a go-to resource. If your patient comes in with the chief complaint of a headache, we want to prioritize the history of headache and its chronological patterns. Again, using the review courses information, pain evaluation, we're looking for location, length and duration, quality, activities associated with pain, timing, trends, associated symptoms, and triggers. We'll review the three most common headache. Number one is tension headache. Number two is migraine. And number three is cluster headaches. The most common headaches are tension headaches, being 90% of the cases. Tension headaches have a very important identifying factor that would be the location. So usually the location is going to be the back of the head and then the neck area. Symptoms do not have any associated focal neurological symptoms. Quality is going to be tight, tense, or vice-like, and usually is noted as generalized. The timing usually lasts for several hours. There's really no associated labs that identifies this, and the treatment is that they try to take a nap for about 30 to 45 minutes, exercise relaxation technique, decrease stress, and OTC analgesics. Next is migraines, second most common headache. Migraines are broadly categorized into two categories. The first is your classic migraine. Everybody knows this one. It's characterized by the presence of an aura, a sensory or visual disturbance that precedes the headache. And the second type is known as the common migraine, which occurs without an aura. From a physiological perspective, migraines are associated with the dilation and excessive pulsation of the branches of the external carotid artery. This was emphasized, so kind of remember that. And this vascular activity is a key element in the development of migraine symptoms. Migraines usually begin in adolescence or early adulthood and often have a familial pattern. So somebody in the family has had a history of migraines also, most likely. And interestingly, females are the most frequently affected sex than the, counterpart males. One defining feature of migraines is their focal neurological symptoms, setting them apart from the tension headaches. Patients often experience cranial or trigeminal facial pain. The pain often follows a trigeminal nerve pathway, which is crucial in understanding the location and spread of migraine pain. The symptoms of migraine include unilateral lateralized throbbing headache that can occur in different episodes. The pain typically starts dull and gradually intensifies, lasting several hours or more. Focal neurological disturbances such as visual problems, including field deficits or visual hallucinations like stars, sparks, or zigzags, lights are common. Other symptoms may include aphasia, numbness, tingling, clumsiness, or even weakness. Additionally, nausea, vomiting, photophobia, and phonophobia are often reported. So various triggers are also known to precipitate migraine attacks. These can range from physical stress, hormonal changes like menstruation, lack of sleep, emotional stress, hunger, and even certain foods and beverages. Notably, nitrates found in some foods like cheese and wine, as well as changes in weather, can also trigger migraines. When evaluating for migraines, the physical exam is often normal. However, it's crucial to be looking for neurological deficits that align with migraine symptoms. Patients may appear ill, emphasizing the need for more thorough neurological examination to rule out other conditions like maybe a brain tumor. To accurately diagnose migraines and rule out those other organic causes, certain baseline studies are indispensable. These include BMP, CBC, a venereal disease research laboratory test, erythrocyte sedimentation rate in ESR, CT scan of the head, and additional studies might be needed based on the patient's history and physical exam findings. Effective management of migraines often involves identifying and avoiding the known triggers. One trigger that was particularly emphasized was their certain food triggers. So stress management and relaxation techniques also play a pivotal role in reducing the frequency and severity of migraine attacks. For patients experiencing frequent attack identified as more than 2 to 3 times a month, prophylactic daily therapy is recommended. First, let's talk about acute attacks and how to manage those. So if a patient is having an acute attack, migraine, you want them to rest in a dark room and have them take their designated analgesia immediately as soon as they feel the onset of the migraine. Other medications that they can use are sumatriptan, a serotonin receptor agonist, and is often used to relieve the pain and other symptoms associated with migraine headache. For the treatment of acute attack, have them start with Imitrex 6 milligrams subcutaneously. For the acute treatment of migraines, this dose can be effective in providing rapid relief from the migraine symptoms. The option to repeat the dose in 1 hour if the migraine symptoms do not adequately resolve with the first injection is also standard practice. This provides flexibility for the patients who may not have responded to the initial dose. Limiting the total daily use to 3 injections and not exceeding 18 milligrams of sumatriptan or Imitrex in 24 hours is important for safety. So overuse of triptans like sumatriptan can lead to medication overuse, headaches, and cardiovascular events or other side effects. It is really crucial to educate your patients on the proper use of sumatriptan, including how to administer the subcutaneous injection and the importance of adhering to the prescribed dosage limit. Patients should be also well informed about potential side effects like sensations of tingling, heat, heaviness, pressure, or tightness in various parts of their body, and more rarely, serious cardiovascular events. So it's really important that before prescribing that sumatriptan, assess the patient for any cardiovascular risks. Triptans are contraindicated in patients with certain cardiovascular conditions, uncontrolled hypertension, and a history of stroke. There's also the option for an oral form of Imitrex that can be used for acute attacks. In the class, they recommended 25 milligram tablet, which is usually prescribed as an alternative to the injection. It has a slower onset, but is still effective for acute migraine attack. For an acute migraine attack, triptan oral tablets are often prescribed in doses of 25, 50, and 100. Again, in the class, they said 25, and depending on the individual patient's need and response. If the initial dose alleviates the migraine, but the symptoms reoccur, a second dose may be taken, but the minimum time interval recommended between the first and the second dose of oral sumatriptan is usually about 2 hours, not 1 hour like the sub-Q form. And then there is a total daily dose of oral sumatriptan that should not exceed 200 milligrams when taken orally. The limit includes all doses taken within the last 24-hour period. There should be some considerations for redosing when you have the oral form, because if the first dose does not provide relief, the efficacy of taking a second dose for the same attack is uncertain. So clinical guidelines generally recommend not taking a second dose orally for the same attack if the first dose was ineffective. However, it can be used for a separate attack on the same day as long as the total daily dose limit does not exceed it. As with any medication, and prescriptions of sumatriptan should be individualized based on the patient's medical history, frequency, and severity of migraine attacks and response to the treatment. Always consider the most current clinical guidelines and recommendations when prescribing medications for migraines. Those patients that experience those frequent attacks for more than 2 to 3 times a month, we spoke about having a prophylactic daily therapy, and the options include what we have here, the anticonvulsants, which is Topamax, and then valproic acid, which is Depakote. Then we have the beta blockers. Metoprolol was emphasized, which is low pressor or Toprol XL, and then there's propranolol or atenolol. We have Botox that is also approved, botulinum toxin injections face and scalp every 3 months. Then we have the NSAIDs and the triptans that we just talked about. But naproxen is supposed to be really good with the NSAIDs. And then the calcitonin gene-related peptide inhibitors. I'm going to just say the Aimovig and then the tinazumab. And then we have tricyclic antidepressants, which we have nortriptyline and amitriptyline. We have calcium channel blockers that we can use, diltiazem, cardizem, or verapamil. There are others. This overview only provides a snapshot of migraine management, focusing on aspects relevant to the AGACNP boards. Remember, this is not an exhaustive list like any of my slides, but it covers key treatments and considerations. Always tailor your approach to each patient's unique needs and symptoms. Let's do understanding cluster headaches. Cluster headaches are known for their extreme pain, predominantly affecting middle-aged men, and often do not have a familial pattern, unlike migraines. These headaches are unique in their presentation and severity, and it's crucial for healthcare providers to recognize their distinct characteristics. Let's talk about triggers and characteristics. So, alcohol ingestion can precipitate cluster headaches, which are marked by intense unilateral periorbital, typically around one eye, pain. The pain of cluster headaches is often described as one of the most severe types of headache pain. Cluster headaches have a distinctive timing pattern. They often recur daily for several weeks, predominantly occurring at night, and they often wake up the patient from their sleep. Each headache episode typically lasts less than 2 hours. Notably, there are pain-free periods lasting months or weeks in between the cluster of attacks. Alongside the hallmark severe headache, patients may experience symptoms on the same side of their headache, such as ipsilateral nasal congestion, rhinorrhea, and eye redness. These associated symptoms are key indicators in diagnosing cluster headaches. For healthcare providers, particularly those in acute care settings, understanding the urgency and intensity of cluster headaches is essential. Their distinct pattern and associated features set them apart from migraines and other headaches. During a physical examination of a patient experiencing a cluster headache, it is common to find no abnormal findings. However, there are specific signs that align with this condition, which are crucial to recognize. Key signs you may observe include redness of the eye on the affected side and rhinorrhea or nasal discharge. These symptoms are ipsilateral to the headache and can guide you toward a correct diagnosis. When it comes to treating individual cluster headache attacks, the approach differs significantly from the migraines or tension type headache. Oral medications are often insufficient due to the rapid onset and the intense nature of the pain. Effective acute treatments for cluster headaches include inhalation of 100% oxygen, so administering high-flow oxygen via a non-rebreather mask for about 15 to 20 minutes can provide significant relief. The imitrexion 6 milligram subcutaneous medication, known for its use in migraines, is also effective for cluster headaches when given subcutaneously. There's also this ergotamine tartrate, is I think how you say it, but ergotamine tartrate aerosol inhalation, or ergostat. This is another effective treatment option, particularly useful in patients who cannot use the sumatriptan. The rapid onset of cluster headaches necessitates prompt treatment. Understanding these effective acute interventions is crucial in managing this debilitating condition. As you prepare for your AGACNP boards, remember the unique aspects of cluster headaches, especially in terms of physical examination findings and treatment strategies. This knowledge is essential for providing effective care to patients suffering from the intense headaches of this disorder. Okay, pop quiz. Imitrex, what is it used for? Choose all that apply. So we have A, cluster headaches, B, migraines, C, tension headaches, or D, none. If you chose A and B, cluster headaches and migraines, you are actually listening to me. And those are the correct answers, A and B. Well, that's it, everybody. Thank you so much for studying with me. For more resources and detailed study materials for the AGACNP boards, please explore all my other offerings on my page. Thank you. See you guys later. And please let me know if you have any questions.